Sawadika and good morning. It's my great pleasure to be here today to share the topic that is close to my heart as a pediatrician, from birth to adulthood, the life course of people living with perinatally acquired HIV. Since 1996, when we have advent of the highly active antiretroviral therapy, it's a good news because it's changed the life course from HIV, from fatal infection, into chronic non-communicable diseases. So I would like to do some experiment and need your support. So please sit back, close your eyes, and imagine that you are 10 years old self, and then you go through some things 20 years. How do you feel? And what do you think about your life course ahead for 20 years? So this is the one that so please remember how you feel, and then please open your eye to listen to my talk. Thank you. And this is the things that I go back to the expert, which is the adult living with lifelong perinatal HIV. They call themselves as a Dek Tank, which is, you can see the iconic building of HIV-NAT, because there was care from the staff at HIV-NAT and also the King Chulalongkorn Memorial Hospitals. About 10 of them, they're growing up together. They come together in one afternoon, reflecting their life, and it's my honor to be their representative to bring the voice and life story. The first decade, the unknown, represent early childhood. We did not understand what was happening. We only knew that there was something different, something mysterious about ourselves, frequent hospital admission, take several of medicines. Very few friends play with us. The second decade, searching. Over time, the mystery became clearer bit by bit. We were told by doctor or parents that we are living with HIV. From that moment, we had to search for our own way forward, to find a path out of confusion, fear, and the emotional fog that surrounded us. The third decade, light and bloom. We discover hope, clarity, and a direction in life that is truly our own, to move forward with confidence. Today, taking roots, we have grown our own roots, brightness, and strength in our lives. Yet, at times, there is still uncertainty. Starting a relationship, committing to build a family, having children, or soaring in our career. Sometimes we wonder, are we going to face with the long-term side effects of HIV drugs that save our lives? Or are we going to face early death? Will our lives remain stable? Or one day it will return back to the unknown again? So this is the things that we should figure out together in a brief 20-minute session. Even though you are scientists, you are clinicians, or you are policymakers, how we can help this special needs group. So I would divide my talk into 3 parts. The first one in epidemiology. This very beautiful viewpoint wrote by Dr. Annette Sohn, director of Treat Asia. She called that, it's time for a generation shift in HIV care. There are millions of children growing up with HIV that I would like to call PA-HIV as an acronym in this talk. They have a unique generation. According to the UNAIDS 2023, there are more than 600,000 AP-HIV aged 20 to 24. They have a key health challenge that is specific. Harbor drug-resistant mutations from exposure to multi-class of ART or even exposed to mono or dual therapy. They might face with the early onset comorbidities due to the chronic inflammation from HIV or due to the period of exposed to several drugs that might cause side effects. Also, mental health issues that they contributed for their orphanhood, stigma, or discrimination. So there are a need for evidence-based guidelines to treat and care for these groups to implement in low and middle income countries, as well as standardized provider training to effectively implement them. This is the data that was collated by Dr. Panathon, who is the Cypher Fellow. He go into the Thai National Database, which is the computerized database. Since 2008, there are more than 4,000 children living with HIV registered in the database. What is their status? 15% of them die, 15% of them lost to follow-up. And among the ones who are under care, you can see that the median age right now is 17 years old. So they are growing up into that special needs. What is the survival rate? It depends on when you was born. In this graph showing in blue, if you are from early 1990s when there are no ART, the trajectory that you are still alive and on care is only 55%. But if you are in a later stage in the cohort, born after 2005, right now about 75% still in care. 90% of them can achieve viral load suppression, and about 80 to 90% of them receive DTG, except the young cohorts that DTG access for pediatric formulation is not yet widely available in Asia Pacific. And when we zoom down into individual level, it was funded study by Treat Asia again, which is the big support for the pediatrics in this region. It was led by Dr. Linda from Lighthouse. We contact individual children. About 800 children was cared for at 5 clinical research centers, and we have data up to 15 years old. And then we reach out to them again, and we find that 7% die during the transition age of 18 to 24 years old. And among the 93% who are alive, about 1/3 is in pediatric care, and then 2/3 in adult care. The second part is on the clinical. Can you raise your hand who is taking care of people living with HIV in the age of 18 to 24? Oh, quite a big groups. Okay, so this part of the talk is for you. So it's about clinical that I would like to address 3 things. The first one is consideration of ART strategy for AP-HIV. Follow up from the talk from Iskandar this morning. When we talk about the WHO updated guideline, either standard integrase inhibitor-based 3-drug regimen, 2-drug simplification, or long-acting. How this guideline pinned down to the AP-HIV, what does it mean? So the aim of treatment is to maintain long-term viral suppression and mitigate risk of long-term non-communicable diseases. However, they might have more drug-resistant mutation. So this is the data from cohort from UK Imperial College of about 300 AP-HIV with a median age of 26 years old. Even though currently cross-sectional, they may have viral suppression, but about 50% of them harboring at least one class of one drug-resistant mutation, which make you have to be very careful and review all the drugs that they have since they was young in order to construct the proper regimen. The second one, the NNRTI-resistant harboring is about 37%. So this might compromise the chance to use cabotegravir as a long-acting injectable because they're harboring some drug-resistant mutation. The good news is that integrase inhibitor resistance is only less than 1% in high-income countries when you have individualized treatment. However, in a country when we use public health approach, don't have frequent viral load monitoring or drug resistance. This represents data from sub-Saharan Africa in the IDEA network. They go to cross-sectional study among age 10 to 19 years old who have virological failure, and then do a drug resistant. This data is from clinical service, not from clinical trials, from 7 countries. About 400 samples was selected. And it's showing that among 40% who have confirmed virological failure, it means that 50% had viral suppressed after do adherence counseling or intervention. But among who have confirmed virological failure, the integrase inhibitor resistance is 26%, which is very alarming, and need to monitor that how this will affect the long-term viral suppression. And also the pattern of drug-resistant mutation is different from what found in North America. The common mutation is G118 and E138. And also there are some differences from the subtypes. So I think even though we might feel complacency that we have a single-dose DTG treatment, but this might not be as last long, especially in the groups of PA-HIV, which have harboring drug-resistant mutation. The second one on 2-drug regimen for treatment simplification. In the past, it's more focused in adult or elderly because you start to see renal complications or cardiometabolic conditions that you want to drop tenofovir. However, this one also should to consider to start using early in adolescent because in order to prevent the future or prevent the potential problems on the renal or cardiometabolic conditions. but it still have issues in low and middle income countries. Like Iskandar mentioned this morning, that in the region in Asia Pacific, we don't have fixed dose 2 drugs regimen. So if we want to have it implemented, it should be generic combination. And how about long-acting injectable capripivirine? The study is called MOCCA study that was talking about the PK, pharmacokinetic, and acceptability and side effect among adolescents 12 to 17 years old. It's have about 144 participants, and it showed that the acceptability is good. The blood level of pharmacokinetics showing in the black line in dot, comparing to the blue one, which is in adult. So it's showing that the level of cabotegravir is a little bit higher than in adult, but it's in the acceptable range and not have side effect. And if you want to learn more about pharmacokinetic, I would invite you this afternoon to the workshop and then listen from Tim Cressy, the expert, on how to use long-acting in pediatrics and adolescent. And there is ongoing study called LATA study, which is conducted in Africa, in sub-Saharan Africa, to see the implementation in adolescent in sub-Saharan Africa, which the data will come out this year in 2026. So, and how this was applied to AP-HIV, because you have a prevalence of NNRTI resistant that might not be eligible. And also data that was conducted by Dr. Panathon, also seeing that when you interview adolescents who just recently acquired HIV and the one with PA-HIV, they are also reluctant to change to the injectable, because they say that in the past they was told that you have to stick on the regimen. And if it's work, stick on that, because it might save you the regimen that you need to use in the next few decades. So I think they need to understand that how this works, and it can work well if they can access to treatment. So the second part is on the aging and comorbidities. If you're taking care of aging population, 50 years old, 60 years old, you will have a solid guideline how to manage cardiovascular risk, how to start antihypertensive drug, how to start statin. But this guideline for 20 to 40 years old population is still lacking. It can be increased risk due to systemic inflammation, immune dysfunction. It can be increased risk because they have prior CDC or low nadir CD4 count when they are young, that make them increased risk of cardiovascular complication. I would show you some case report and cases that I saw in the clinics. Please help me. I think many people in the room is internists or seeing their patients. This might be easy for you, but it's difficult for us as a pediatrician. So this is a case report by Dr. Alison Agu from Johns Hopkins. She report a case of 24-year-old male AP-HIV that stopped discontinued ART and presented at emergency room, very cachexia, CD4 only one cell, and have electrolyte imbalance. And after admission, and then he developed pressure-like chest pain, and EKG showed prominent ST elevation on anterior wall, and then coronary angiogram showed long, hazy stenosis at the mid-segment of RAD with thrombolysis in myocardial infarction. So what does it mean? You might not surprise if this is 50 years old or 60 years old, but this is 24-year-old. Do you have this kind of patients, similar profiles in your clinics? Someone who struggle with ART, low CD4. Usually you will think about complications like PCP, cryptococcal meningitis, but do you well prepare to handle this kind of emergency? So this patient, he was diagnosed as 5 years old on ART, 10 to 19 years old smoothly. But then when they are 20 years old, he have to be on his own. He has unstable housing, intermittent employment, and discontinuous ART. He has smoking, and the lipid profile is not that high. The question is, how do you know which one will proceed to this stage, and which is a right timing to start intervention, both lifestyle modification and also medicine? This is the case that I don't know how to do. Please help me figure out. This is 26 years old, AP-HIV, diagnosed from 10 years old. He had no problem with viral suppression. But when he was start to be young adult, his body weight is keep increasing, he has persistent hypertension, his creatinine starts to increase. He don't have diabetes yet, he don't have high dyslipidemia yet. But when, where you should intervene. So in these cases, in our clinic, what we can do, the first thing is to simplify regimen to stop tenofovir, because we are confident that the viral suppression efficacy still remain the same. And then we can bring down the creatinine down. However, with the hypertension, do we need to start ART? Do we need to start antihypertension? Who think that we should start now? Who think we should wait? Who think we should refer to colleagues in cardiology unit? No. So we don't know whether we should give them a time to do behavioral modification, or we should start strictly and make them feel very concerned that in the next 30 years I will have heart attack. So there are no solid guideline at this point. So when we research literature, they will talk about P-Day score. So how many of you use P-Day score or heard about it? Very few, so I feel normal because I also start to learn about how to use P-Day in the clinics or how to do research on this one. It's called Pathobiologic Determinants of Arteriosclerosis in Youth. Try to characterize or forecast risk among 20 to 40 years old. What is their risk in the future when they are in the future? So the P-Day scores using the risk factors including age, sex, non-HDL cholesterol, HDL cholesterol, obesity, hyperglycemia, but have to be over DM, hypertension or smoking, and then calculated score. The bottom line in the clinics is that usually in our Thai national programs, we didn't do HDL as a routine. We might need to start to do it in order to calculate the risk. And this is the data recently published from UK and Cape Town showing that they characterize the P-Day score cross-sectionally in the clinics. The median age of 27 years old, duration of ART of 19 years. They're showing that 9% start to have hypertension, but they also not have a solid guideline when to start antihypertensive drugs. And about half of the clinics have P-Day scores more than 1. The data from Cape Town also shows similar, despite that the median age is much younger, it's about 17 years old. 1/3 also have P-Day score. And also the associated factors of high P-Day score or higher risk of cardiovascular risk in the future is sustained viremia, have 18 times higher risk compared to the one of viral suppression. So bottom line that we can do right now is to maintain viral suppression is one of the protective factors for the future cardiovascular risk. We also will start the papaya candy funded by Treat Asia again to try to characterize the P-Day score in Thai children. And then it's still the area for the research, if you are the research or scientist, to think about how to characterize that. The third part is on the mental health issue. The mental health is abstract, how we can do it. So I summarized that there are 3 S that you can use in clinics. The first one is to assess suicidal risk or mental health well-being. You can use the simple PHQ-9 questionnaire or simple asks about how do you feel or have any suicidal ideation. The second one is stigma. Stigma is abstract. It's something that was happened to them, but sometimes we cannot do much about it. So in our clinics, the child psychiatrists advise us to boost the self-esteem every time in the clinic, at least to counteract with the stigma. And the last one is about sharing HIV status or disclosure. In this group, they will do it twice. They will disclose by their parents to them about the HIV status, and then they will also have to disclose onwards to other people that they care about, family, friends, or partner. So the first time that you do disclosure to the child is so important. You have to be in a positive way. You can say that you have some virus, but we can have treatment. And if you can control them, it's very unlikely that you're going to pass on. But this generation was disclosed 10 years ago, 15 years ago, that you have something secret you cannot tell anybody. It might be dangerous to tell anybody. You cannot have sex, you cannot have baby. And that one make it very stigma. about how they was told about themselves and make it very difficult for them to tell it onwards to other people. So this is the data from our CU Buddy Clinic that we do mental health screening and intervention integration in our clinics. The data showing that about 27% have mental health issues. 7% ever suicidal attempts. And very sadly, last year we lost one. So you have to be very careful and make the abstract to be measurable, ask, or open the door for them to talk about mental health. Majority is major depression. And we have an opportunity to work as a collaborative care model to be able to do screening, management, integrated within our clinics. So I think this one is very important. Second one, stigma. Stigma is a negative attitude, beliefs, or stereotypes about people with HIV or associated groups. How you ask stigma in the clinic? Do you ask or not? You can use simple questions. Anticipated stigma is that, do you think that you might face with something or be treated differently because of your status? Or you ever have someone discriminated you, is enacted stigma? Or how do you feel about yourself? Which one is the most difficult one to deal with? Who think that is anticipated stigma? Enacted stigma? Or internalized stigma? To me, internalized stigma is the one that's very deep down. So I think we have to assess because it's something that on the surface, a child might have viral suppression, good CD4, but they have something that they need to talk about and its effect on adherence and also transition to adult care. So how to boost self-esteem? Active listening, non-judgmental, positive reflection in order to highlight strengths and achievement. For example, if you have adolescent come in, miss appointment, high viral load, what you gonna say? In the self-esteem mode. Thank you for just coming. Even though you feel sick, I'm very appreciate that you can come here today. How we can help? That kind of thing that is boost self-esteem because they need to boost self-esteem and not judgmental them and then push them away. So remember, even though inside you might feel like, what regimen you can use if you have failure, but you need to boost esteem and help them to be able to keep up the strength and then move on and then be able to cope with stigma. Sharing disclosure, as I mentioned, there was being told, and why disclosure is important because it's the first step. It's the first step of transition. It's the first step that we build health literacy, empowering them to be engaged and increase participation in decision-making about themselves, and we should start from school age. However, for disclose one's own HIV status to others, it's recommended to start asking simple questions. In the past 6 months, do you feel you want to talk it to someone? Or have you talked it to someone, and how was that? Do you want to share? This is a simple question that you can ask in the clinics in order to open the door for them to talk about this. Why disclosure should be done? Because it's proof that it would improve the mental health, and it could be done in a way that have autonomous decision-making, addressing layer of stigma, and also adopting right-based approach to keep their privacy and autonomy to make that disclosure happen. This is a study in UK and Uganda called Heads Up. They have programs, a session to help them start with general HIV talk, to evoke the decision, do you want to share or not share? What is the pros and cons? And then develop HIV sharing skills to be practiced where and when and how and what you want to say about yourself. And then the last one is individual session. Help them to set a goal if they want to share to someone, set an action plan and then coping plan. This is another thing that we can do to help them if they want to disclose. And this is the data from our CU Buddy Clinic, even though it's from the BHIV groups. It's showing that adolescents, 84% of them talk to someone else. They didn't want to keep it themselves. And they're showing that even though 80% of them feel that it's uneasy to talk, but 80% of them feel like it's improved my mental health and been a positive experience. So remember, 4S, suicidal assessment, stigma and boost self-esteem. And also the last one is about sharing experience of HIV. The last part is for the programmatic. When we talk about transition in life, or transition into adult care, from pediatric to adult care, or transition the clinics that they need to go to for the ART because of the change or mobility in life, we talk about preparing them to have equipped to be able to move from children to adult service. However, to me, to be fair, we should also transform our service, even via pediatric care or adult care, in order to have skills to deliver patient-centered care for them. This is an example of how we prepare transition process from the UK clinic, from Imperial College. It's a process. They start to talk about the issues that one day you cannot be in our clinic. You might need to go somewhere because of go to university, have a job, or change clinics. So how we can prepare them. The first step when they are teen, they would transition, explain to them and help them to understand about HIV disclosure and also treatment. 15 to 16 is a period to start to navigate HIV care. And then 18 is the time that you can choose. Either you have transition clinics or you change the clinic and then have a follow-up. So the transition to adult care, it should be personalized and not use any age cutoff. Assess whether they are ready or not, because it's a scary process and you might lost, as I previously showed that 7% die during the transition age. And also, it's a time of mobility. So trying to use mHealth or technology to track them in order to check whether they are still okay, or be able to reach out for you as a telehealth or something to be re-engaged in care if they need it. Because the pediatric care is the one that they are build trust and then relationship with and be their lifeline. And the last one, don't forget to address stigma and disclosure issue. It's not just a CD4 or viral load as a checklist for them to be able to be taking care of themselves, but deep down into some abstract issue on stigma and disclosure. So this is almost the last slides of what we did in our CU buddy. In summary, we would do assessment using strength-based. In old school of adolescent, we would call HATES. We would start about home, but children was not live at home. For the things that would be easy conversation, we should start with strengths. How was your friend? How was your home? How was your activities? You can see that we start with fun things. We start with self-esteem. We not start with the risk. Drug substance, sexuality, or safety would be after they open their heart and feel trust with you. And this is a slide that I really like from Dr. Vipaporn, who set up the adolescent clinic in our hospital. Not judgment, and be a safe space or helpline always there for them. You can be pediatrics clinic, you can be adult clinics, you can be primary care clinics, you can be emergency room. But if you transform yourself to be a friend or someone who will go through that journey of the life course of PA-HIV, it will be help to help them go through the process on the right course. So I'd like to end with this summary. Remember, if you are 10 years old, go through this 20 years. They might ups and downs, and they are not only medical issue, not only ART, and many mental health or developmental over time. Millions of children living with HIV is growing up into this generation. We need to manage an optimization of ART, considering of all the factors of this generation and this spatial group, promote mental health and self-esteem through services to support their transition to adulthood, and help to make sure that when they take their roots, they can growing up, blooming, and not going back to unknown. Thank you very much.